Hello, everyone. The topic which has been given to me today to highlight how do I use OCT in relation to glaucoma. OCT has become an useful tool in relation to glaucoma diagnosis and management, provided it is used properly. As per my personal observation, OCT in glaucoma is perhaps the most abused machine in ophthalmology. It can be used for diagnosis in pre-perimetric glaucoma and early glaucoma, as well as it can also assess the progression during the glaucoma management. For proper utilization of the device, understanding of two concepts should be very clear. Firstly, which pictures does it take? What structures are scanned? So we have to understand that whatever pictures we are getting, what is the basis of these scans, and whatever we are getting, how to interpret that. Along with that, we have to also understand the strength, limitations, and fallacies of those recordings or those pictures. Secondly, we should realize that glaucoma is a progressive optic neuropathy. Therefore, assessing progression is really very important, and it is important for two reasons. One is for confirming diagnosis of pre-perimetric glaucoma, because unless it shows progression, we cannot say for sure that it is the diagnosis of glaucoma is perfect. The second is assessing the sufficiency of treatment. In the course of treatment, with whatever medication or laser treatment or surgery we have done, intraocular pressure reduction is the main target. But whatever target pressure I have attained, whether it is sufficient or not, this is judged again by assessing the progression, for which OCT becomes an important tool if it is used properly. Some of the points which we must remember whenever we are using OCT. First of all, understand the fundamentals of OCT in glaucoma, which I am sure in this entire series, it will be explained properly. What does it scan? Optic nerve head, circumpapillary retinal nerve fiber layer, and macular area. Now, these assessments, they are used either in isolation or in combination for analysis. Also, we should realize that all machines do not measure the same thing, hence understand the machine on which the test has been performed. The data of different machines are not transferable and not interchangeable. So if you are doing it just for once, then it is okay, but that is not sufficient for the management of glaucoma, because we have to do the follow-up testing so that we can assess the progression. Therefore, it should be, all tests should be done on the same make and same location of the machine, so that our baseline reading as well as all follow-up readings are there in record, and we can have an analysis of progression. Whenever we see a scan, the scan strength should be acceptable, means it has to be sufficient. The quality of a scan should be good, otherwise there is no point interpreting that. And also the machine that you are using, it should have a small retest variability. The machine should have reliable registration and tracking system, so that every time the scan is done exactly at the same location. We should also understand the floor effect of the measurement. Floor effect, what I mean by that when the retinal nerve fiber layer thickness is reducing because of the degeneration of the nerve fiber layer, But in that, there are certain glial tissue, supportive tissue, and blood vessels that remains stable. So if all the nerve fiber layer have degenerated, then it is the rock bottom layer that we are getting, measurement that we are getting. Less than that, we cannot get. Therefore, the floor effect we must realize whenever we are assessing the progression. OCT becomes very important if the patient cannot perform perimetry, because this is objective test, whereas perimetry is subjective test. OCT is not of much use in advanced glaucoma. Artificial intelligence to be used judiciously, because we always consider that whatever the machine tells based on the artificial intelligence is sacrosanct. It's not. We should be careful in abnormal discs such as tilted disc, large parapapillary atrophy, high refractive errors, vitreous floaters, etc. In these situations, macular analysis is superior to retinal nerve fiber layer analysis around the disc. And beware of artifacts, macular pathology, segmentation error, and decentration error. Because a slight decentration error will change all the figures and it will jeopardize the analysis of progression. And macula, remember that it can have many other pathology where the thickness can vary, can change. So we have to consider that also in the analysis. Now, finally, I'll just say a couple of points that how do I use OCT in glaucoma? First of all, take care of the points which I have summarized just now. I never start treatment only on OCT findings unless it is collaborating with the other findings, means clinical correlation and other tests. In pre-perimetric glaucoma, I usually do not start treatment if there are no risk factors. But I follow up diligently and confidently on OCT to detect any progression which will tilt the balance towards treating them at that point in time. If there is no progression, I continue follow-up, but at longer intervals. In pre-perimetric glaucoma, if many risk factors are present, I start treatment and follow up regularly on OCT as well. Because of the progression, now my diagnosis is confirmed of glaucoma, which just now I enumerated in my earlier portion. In early glaucoma, it aids in diagnosis and helps in assessing the progression monitoring. It is really helpful in those patients of glaucoma who cannot perform perimetry in spite of multiple attempts. Now, also remember that OCT is not everything. I do not give priority to OCT over perimetry, because perimetry definitely gets priority over OCT. OCT is a supportive investigation. I do OCT in glaucoma patients, but repeat more frequently in the situations described earlier and less frequently in other situations. Also, it has very limited role in advanced glaucoma. So friends, I hope if you take these points into consideration, I am sure you will use OCT in relation to glaucoma optimally. Thanks a lot for your patient listening.